Welcome to the friends. Today we will discuss about tetralogy of Fallot. This is complex defect consisting of right ventricular outflow tract obstruction and right ventricular hypertrophy, a large ventricular septal defect, and an overriding aorta that, when combined with the septal defect, allows blood to be pumped directly from the right ventricle into the aorta. It occurs in about 1 in 2000 births and is the most common cause of cyanosis in infancy after the first year of life. Now, pathogenesis. Tetralogy of Fallot occurs as the result of abnormal development of the valvar septum that separates the ascending aorta from the pulmonary artery and which normally aligns and fuses with the outflow part of the interventricular septum. The right ventricular outflow obstruction is most often subvalvular or infundibular, but may be valvular, supravalvular, or a combination of these. The subvalvular component of the right ventricular outflow obstruction is dynamic and may increase suddenly under adrenergic stimulation. The ventricular septal defect is usually large and similar in aperture to the aortic orifice. The combination results in elevated right ventricular pressure and right to left shunting of cyanotic blood across the ventricular septal defect into the aorta. This figure shows tetralogy of Fallot. The tetralogy comprises pulmonary stenosis, overriding of the ventricular septal defect by the aorta, a ventricular septal defect, and right ventricular hypertrophy. Now, the clinical features of tetralogy of Fallot. Here, children are usually cyanosed, but this may not be the case in the neonate because it is only when right ventricular pressure rises to equal or exceed left ventricular pressure that a large right to left shunt develops. The affected child may suddenly become increasingly cyanosed, often after feeding or a crying attack, and may become apneic and unconscious. These attacks are called Fallot spells. In older children, Fallot spells are uncommon, but cyanosis becomes increasingly apparent with stunting of growth, digital clubbing, and polycythemia. Some children characteristically obtain relief by squatting after exertion, which increases the afterload of the left heart and reduces the right to left shunting. This is called Fallot's sign. The natural history before the development of surgical correction was variable, but most patients died in infancy or childhood. On examination, the most characteristic feature is the combination of cyanosis with a loud ejection systolic murmur in the pulmonary area, as for pulmonary stenosis. Cyanosis may be absent in the newborn or in patients with only mild right ventricular outflow obstruction. However, this is called acyanotic tetralogy of Fallot. Now, the investigation. Echocardiography is diagnostic and demonstrates that the aorta is not continuous with the anterior ventricular septum. The ECG shows right ventricular hypertrophy and the chest X-ray shows an abnormally small pulmonary artery and a boot-shaped heart. Now, the management. The definitive management is total correction of the defect by surgical relief of the pulmonary stenosis and closure of the ventricular septal defect. Primary surgical correction may be undertaken prior to the age of 5 years. If the pulmonary arteries are too hypoplastic, then palliation in the form of a Blalock Taussig shunt may be performed with an anastomosis created between the pulmonary artery and subclavian artery. This improves pulmonary blood flow and pulmonary artery development and may facilitate later definitive correction. The prognosis after total correction is good, especially if the operation is performed in childhood. Follow-up is needed to identify residual shunting, recurrent pulmonary stenosis, and arrhythmias. An implantable defibrillator is sometimes recommended in adulthood. Thank you, viewers.